Welcome to The Homegrown Heart with your host, Dr. Amanda Ryan, DO, MBA, an interventional cardiologist, and a recognized expert in that field. This week's topics: see how we develop the Heart and Vascular Center of New Mexico. But first, we're going to meet Perm, and he's going to take us around the facility and introduce us to some exceptional staff members.
Good morning. My name is Jonte, a.k.a. Perm. I'm the IT director here at Advanced Heart and Vascular Center of New Mexico. And I'm going to take you guys on a tour of the building. We're going to talk to some people so you can meet some of the wonderful staff that we have here that makes the magic happen. Let's go check it out. Go in the monitor room. As you can see, this is the cath lab. Let's go check it out. State of the art. This is where all the magic happens. Nice and neat and organized. The supplies. All that jazz. There he is. Well, who do we have here?
Oh my gosh, I almost needed you. I thought you were already in Artesia.
Hey.
Hi, oh thank you. I thought you were in Artesia. I needed you because soccer is life.
Football is life.
Football is life. And I thought that I couldn't watch the Euros and Copa today because I have 50 patients and like 5 cases, but I have to watch it. Or
You gotta check in.
I have to at least like glance. And I couldn't get the TV to turn on. I even changed the batteries myself. This was major. I changed my own batteries and then it still wasn't working and I felt devastated. But I made Ray and Nyla like, okay, look, you have to take a break from rooming the patients. You have to make sure that this remote will work because if I can't watch the Euros, I can't function, okay? And they got the seriousness of it and all of a sudden my TV is on over there ready for 10 o'clock, Italy versus England. I'm ready, okay?
Let's go football.
Go football.
Oh man, that's gonna be great.
All right. That's like a real story.
It is, yeah.
I was like,
Hey, player, it's your turn. It's your turn. Come on, player.
sorry.
Gotta get this stuff going on, you know what I'm saying?
What's up, Perm? How's it going this
State
morning?
your name, gangster.
Algie.
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 Who are you, John B? Algie. What you do here, Algie?
I do it all. I was just on the roof a while ago. You know, yeah, we're trying to keep the roof from falling in. Yeah, got a lot going on today. Monitoring.
So what is your actual title?
Circulating. My actual title, I don't even know. I'm a PACS administrator,
Okay.
radiologic technologist, compliance officer.
Okay.
Just trying to hold the fort down.
How long have you been doing that?
About 8 years as far as PACS administrator.
Somebody might have
Yeah, get her headset right.
Yeah,
dude.
I'll get her headset.
Yeah.
No, just gotta get the headset right.
Yeah, we have Coco with one on there.
Hey, Jez or Coco, probably Jez. Can you turn your headset down or off? Thank you.
All right, quick question.
Yes,
How
sir.
did you meet Dr. Ryan?
We met at the hospital.
Yeah.
So I was there for 23 years, and then the last 8 years she was there, and I worked with her a lot. Did a lot of helping her out with her reports, finding them, making sure she was signing them and whatnot, and everything was flowing across correctly at the hospital with cardiology. So yeah.
Cool. So you say you do a lot of stuff here, jack of all trades, right?
Yes, sir.
What is the best aspect of your job?
I think doing that, a little bit of everything.
Yeah,
Kinda,
being versatile.
yeah, I don't like being stuck in one spot, so.
And I've heard that there's like a beaver colony here or something.
Yeah.
What's everyone has beaver names?
Yeah.
What's your beaver name?
Bad boy beaver. I guess I get put on the bad list a lot, so.
Oh, okay.
Bad boy beaver.
Badass beaver.
Bad boy, badass. I'll go with badass.
Hello, who do we have here?
I'm Sol, one of the medical assistants here at the clinic.
A medical assistant?
Yes,
How
sir.
long have you been a medical assistant, Sol?
5 years now.
What's the best part of being a medical assistant?
Taking good care of my patients
Yes.
and see the smile on them, and they can recognize you every time they come to the clinic.
How did you meet Dr. Ryan?
How I met Dr. Ryan, being medical assistant at family practice, we always refer patients to her, and all the patients come back to our clinic talking great thoughts about her. That's why I met her, and then one time I see that they was hiring for a medical assistant. I applied and I got hired.
Cool beans. So, I know that there's like a beaver colony here, but there's also panda.
Yes, sir. We are the Panda crew, or medical assistant are Panda crew. By the way, I'm Mama Panda.
Mama panda.
Yes.
All right. What animals? So, who do we have here?
Hi, my name is Veronica Ramos. I'm the practice administrator for Advanced Heart and Vascular Center of New Mexico.
Oh wow, I didn't even have to ask my first question. You're already on it.
Yes, sir.
What is the favorite part of your job, Veronica?
Working with diversity whenever it comes to patients as well as staff, and meeting people and them sharing their life stories and experiences and having the ability to assist them with their care.
Okay. How did you meet Dr. Ryan?
Well, I initially met Dr. Ryan in 2016, I believe. I got to know her former office manager, Denise Ortiz, who then recommended that I come work with them at the cardiovascular clinic that she was managing for Dr. Ryan.
Mm-hmm.
It was a little scary feat because I ended up seeking out, medical assisting and what it took to become a medical assistant. Ended up enrolling in a program and getting my certificate as a medical assistant. Applied for Dr. Ryan's office, did an interview with Denise, and they were willing to give me a chance. Previously, I had no prior experience, and I had no idea of how to be a medical assistant.
And everything just kind of went from there.
Yep, with a lot of hard work and, education and training, here we are now.
Good. Do you have a favorite coworker?
I actually don't. I like everybody. The cohesion here is compared to no other place that I've ever worked for.
Right.
Everybody brings something to this company, and every person's just unique and enjoy to work with. I mean, it's different on a daily basis on everybody that you work with and how they are. It's, everybody's just so great here, and their personalities are so different and unique that, there's a special place for everybody here, and, I hold them near and dear to my heart.
Right. What's your name, gangster?
I'm known around here as the Trailblazing Beaver,
What else?
sometimes Bitter Beaver,
And Bustling Beaver.
and Bustling.
You were. Explain to me why we're doing this right now.
Because I was left out of the first video.
And it made you sad.
Yes.
Why?
Because I'm a beaver.
Oh, we're all beavers, right? What's my name?
You are son of a beaver.
Oh, this is
More
awesome.
perfect name has never happened.
For real. What do you do here, Miss Beaver?
I just hang out. I'm just here for decoration.
No, that's not what you do. You're more important than that.
I scrub it on the cases.
And
I sometimes do a house soup.
yeah. Do you like being a house soup?
Not really. I'm not
No?
very good at it.
You seem very thorough when I see observing. Do you like your job, and do you like the people you work with?
Indeed. That's work environment I've
Ever been in, right?
about 19 years.
Really? Well, good. We're glad to have you on the team. And who do we have here?
Nyla.
Nyla, what is your position and what do you do here?
I am a medical assistant and I do patients all day. And now I'm starting to do more.
You mentioned that you're a medical assistant, recently pinned, right?
Yes, I got pinned.
So that means you recently got certified, and how does that feel?
It feels very accomplishing.
Good.
Yes.
How did you meet Dr. Ryan?
In an interview,
Yeah?
but 2 days after the interview, I'm there in person.
Oh, yeah?
Yes.
What made you decide to come and work for ASV?
Actually, so the day that I got called, I saw the website because I was wondering like everything that they did here, and I went on the website and I saw Dr. Ryan's video on the page that we have on HVNM, and I was really inspiring, and I wanted to work at a place that I can grow from, and it's been exactly that.
Do you have a favorite coworker?
No.
I try to jam people up with that question. What do you like most about your job?
That I learn something different every single day.
That's good.
And I get trained, to do different stuff. And now I'm getting trained to be in the cath lab. It's
That's
very
exciting,
exciting,
right?
Yes.
Yeah, it's real serious business over there. So
Yes.
congratulations on that. That's a good look for you.
Thank you.
So I know right as of now you are a panda, correct?
Yes, I am.
And you could possibly be a beaver soon.
Yes.
What is your panda name?
Princess Panda.
How long did it take for me to do this interview?
3 weeks.
Princess Panda it is. Thank you, Nyla.
Thank you, Permisito.
Who do we have here? You ready for your interview?
Sure.
What's your name?
Karen.
Karen what?
Karen Davidson.
And what do you do here, Karen?
I am a registered nurse.
Registered nurse? What do your daily duties consist of?
I'm the director of nursing for the cath lab, and I am the infection control officer for the facility.
Okay, who's this handsome young gentleman right here?
That's my husband.
Oh.
Who, by the way, put all the furniture together here and hangs all our pictures.
Oh, does your husband have a name?
Jerry.
Hey, Jerry, say hi to the camera, Jerry. All right. So, how do you know Dr. Ryan?
I happen to be her mother.
Oh, okay. That must be nice.
Most days, yes.
What is your favorite part about working here with your daughter?
The patients.
Yeah.
Having contact with the patients. I've been a nurse for 45 years in a supervisory role, and I enjoy being with the patients.
Okay, cool. Do you have a favorite coworker?
I enjoy all the girls, and I enjoy their enthusiasm, but I have especially bonded with Veronica, who's our office administrator. She's taught me a lot about billing, which I never did before, and I find it interesting to do new things. So, yeah.
She's pretty awesome, huh?
Right.
All right, so the last question I have for you, are you a panda or a beaver?
I am the queen beaver.
You're the queen beaver?
Yes.
Oh, okay. And that's what they call you, refer to you as? Or Mama Beeve?
They call me Mama K. Beeve.
Mama K.
There might
Beeve.
be other imposter queen beavers. but
Oh,
I am
you're the OG
Right.
queen beaver.
I guess I could be the grandma beaver.
All right, thank you, Gary.
All right, nice to talk with you, girl.
All right, bye-bye. And who do we have here? Hold up, this is your interview.
No, I'm not ready for
Yes, you are. What's your name?
Isabel.
Isabel what? Well, you don't have to say that.
I'm shy.
This is the only day I got to do my interview. Don't do that. I didn't start with you. I got 8 other people already.
What do you want to do? Oh, Lord. Put that camera away. Put that camera away.
Here, there you go. Just
What
like
is
singing
this?
jingle.
Oh, I can't sing.
That's a
I was
microphone.
just joking. This is some,
What's your name?
my name is Andrea. Blondie is my nickname.
Andrea. What do you do here, Andrea?
Kind of a
Gotta
girl
hold
Friday.
the
I'm sorry,
microphone
I'm a
too.
girl Friday here. So a
Girl
little bit of
Friday?
everything.
I don't know what that is.
We check in patients, we go through insurances, we do referrals, we check out patients with Dr. Ryan.
Oh,
We
so
get
like
yelled
a-
at by Isabel when we're not checking in patients on time. Isabel keeps us in line. And what else she's laughing at me, but it's the truth. Perm, am I lying? Am I lying? If I'm lying, I'm
plead
not
the
trying. Perm.
So, what do you like most about your job?
The people,
Yeah.
honest to God. Like, we might give each other a hard time, but Dr. Ryan, I feel like, did a great job handpicking her staff. I don't know how she did it, but
That's nice feedback.
yeah, it's true. She did a great job picking her staff, and I think we all complement each other, and we're all different. I'm the talkative one.
Clearly.
So, what else do you want to know?
How did you meet Dr. Ryan?
Through our friends, Joe and Renee Lopez.
Oh, okay.
Yeah, they were at his 60th, and I didn't even know it. So that's how we met. Well, actually, Joe dropped off my resume without my knowledge, and he gave it to Corbin. So he was sneaky.
Say hi, Corbin.
So that's how I'm here, through friends.
And you're happy that you made that decision?
Yes, very happy. Very happy.
Well, we're glad to have you here.
Thank you,
Andrea.
thank you. You're the best, Perm, and you bring us tater tots.
I'm telling everybody my secrets. Give me my microphone. All right, who do we have here?
My name is Rihanna.
Rihanna.
Yeah.
What do you do here, Rihanna?
What don't I do? I'm just kidding. I'm a medical assistant.
How long have you been a medical assistant?
6 months.
6
7.
months. Oh, so you're
Long time.
you're a
Not long.
tadpole in the
I'm a
game.
baby one.
What do you like most about being a medical assistant?
Helping people. I like that we can make a positive change in other people's lives.
Okay. How did you meet Dr. Ryan?
She was a patient at my previous job as at the chiropractor's office.
Okay, speak up a little bit. It sounds like it might be a little low.
Okay, sorry.
Yes. Are you
I
nervous?
feel very like Ricky Bobby, just standing here with my hands.
Ricky Bobby.
Yeah.
Weird flex, but okay.
Yeah. Weird flex, but let me tell you, I shake and bake all day long.
If you ain't first, you last.
Exactly. Exactly. If you ain't first, you last.
So you met Dr. Ryan at the chiropractor.
Yes.
Okay, cool. What do you like? Where do you see yourself in 3 years?
Still here, but higher up. I don't know. With more roles. Still changing lives and helping people, I guess.
So you found your career.
I found my career here, yes.
Definitely.
I'm a lifer. That's what, yeah.
Whole life?
Full life, bro.
Anything that you'd like to say to the people?
Hi, people. Come in and get your heart checked. Or your legs. I don't know. She does everything. She's a bad bee. She's a baddie.
This is the intro part.
Oh,
so
well,
let's-
she's super great.
all right. There you go. And who do we have here?
Hi, I'm the Queen Beaver. Who used to be the Queen
No, we just spoke to the other Queen Bee who said there might be imposters,
Oh,
but
there could be.
yeah, but that she's the OG Queen Beaver over
Oh,
there.
those are probably.
I mean, I'm just telling you
that
what she
could be
said.
like a honey beaver. You know, I used to be the Queen Bee before I became a Queen Beaver.
Oh,
I
okay.
made
So
it
you
through-
kind of graduated.
Yeah, I graduated. I've been through the insects, and now I'm a. Wait, is a beaver a mammal? Could I ask someone?
Yes, they have babies,
Oh, okay.
fur babies.
Is that how we decide
I don't know.
sexual reproduction?
I don't know. I listen. I'm just running with it.
Have you? Don't you think frogs are weird how they just sort of divide?
Okay, where's this going? Where's this interview going?
No, it's just been fun. And I'm really trying. But I perpetually 200 notes no matter what because, well, which might be like, oh my God, what kind of doctor is she? That's 1 week worth of patients. We're literally serving about an area with 2 or 3 cardiologists that really should have about 8 cardiologists. So to say I'm working in overdrive is an
Understatement.
Yeah.
Yes,
But our whole team's passionate about what we do, and we'll just keep moving on. But about
Okay.
those tadpoles, I was gonna say, and
I got nothing.
the Copa's back on at 4 o'clock. That
Who's
would be,
playing today?
Yeah, that's gonna be Colombia and Costa Rica.
That should be a good one.
Yeah, 4. Okay, I'll be watching that and trying not to focus on notes.
Okay, so today is really not about you, even though everything is about you.
Oh.
I got other people to
Am I
interview,
supposed to talk about
no. They'll get back to you later.
Okay.
All right. Bye-bye. What's your
Hello,
name?
my name's Tammy Wacker.
What do you do here, Tammy?
I am the director of Partners in Heart Health. It is a nonprofit foundation that was founded by Dr. Amanda Ryan here in Carlsbad, New Mexico.
That sounds like a lot and very important. How did you meet Dr. Ryan?
I actually met Dr. Ryan through her mother, Karen Davidson. Karen was my corporate nurse when I worked in the long-term care field as a nursing home administrator. And her and I really got along well, and she knew that I had about 15 years experience working for nonprofits and working as an advocate for older Americans. And so when this opportunity came up, she thought of me and contacted me, and I thought it was wonderful. And I've enjoyed every minute of it since.
Well, good. We're glad to have you here. Anything you would like to say to the people?
Just that this is a wonderful environment to be a part of. It's wonderful to help people, to see the patients coming in, see their family members, how everyone treats each other here, not only as a staff member, but as a colleague and as friends. And it's wonderful to be a part of it.
Well, thank you, Tammy.
All right. Thank you.
Good July Friday morning. My homegrown heart is ready to really get into this week how we developed Advanced Heart and Vascular Center of New Mexico. This is exciting for me to share my mission, passion, and vision with all of you. And I'm looking forward to, again, everyone has an agenda overall when they're trying to start something new or accomplish something. And I'm very excited to share my overall agenda with you, our agenda. Again, I think it's important to remember that this is a team effort. I have a lot of amazing people on my team, from production to nurse practitioners, to family, to patients, that are all important in how we got here. So my goal is to share with you and help gain traction on really what I feel like needs to be a concerted movement to change the way we deliver rural health care. Our mission is to improve the health of the underserved in our rural community with a commitment to excellence in all that we do. Our goal is to offer quality cardiovascular services that set community standards, exceed patient expectations, and are provided in a caring, convenient, cost-effective, and accessible manner. So that is the mission statement of our practice, Advanced Heart and Vascular Center of New Mexico, which, yes, inevitably people ask questions about my tattoos, and this is the Advanced Heart and Vascular Center of New Mexico logo. We call our practice AHVNM. The development of AHVNM was about a 5-year process. I came from a private practice setting in Florida where with 2 other cardiologists who happened to be brothers, we developed a successful cardiovascular program there that took about 8 to 10 years. And then, as I've said in my last podcast, life happens sometimes and you decide to take a different turn. So I came to Carlsbad and practiced in a large corporate setting for about 6 years. About 2 years into that, I started developing ideas for what I thought would be appropriate for an independent rural practice, and the reasons why. So I did walk away from a 7-figure corporate America job in order to borrow $14 million and make a couple $100,000 a year. Boo-hoo, rich people, first world problems, I realize. But that is the level of dedication. And of course, I did it without any money saved. If anybody wonders what kind of position I was in, I think I talked a little bit in the last one that I had a divorce. I was, my parents helped pay for 14 out of 15 of my siblings, nieces and nephews, little cousins to go to college. And those are all true statements. But that means by the time I got to medical school, I was on my own. Between medical school, my first practice, my divorce, unfortunately, and some financial decisions that were mine, some that were other people's. But let's say I came to Carlsbad in about $1.5 million in debt. And even with a decent salary, that's a little bit daunting. And that salary was developed over several years. So it took me quite a while. And the way things don't always transition exactly like you think they will. So as it turned out in that the fifth year I was out here, each month I became free of one bill after another bill. There was literally a time where I think I made $38,000 a month, let's call it approximate, and I owed $36,000 a month in bills. So, and I was living in an inexpensive house, driving a relatively inexpensive car. So sometimes I think as society with physicians, maybe we don't have a total realization of the amount of time and money that really does go into getting your career launched. And I would never change it. But I do think it's important to be realistic about what's facing some of our medical school candidates currently. And it will affect some of the decisions that they make when they get out and the way that they can practice healthcare, truly because the finances do matter. You know, my mom, as I've mentioned, was a smart young person in a small town, and she said, you know, we didn't even really go to college. I never considered, this was in the mid-70s, she's like, I never really considered that I could go to medical school or law school. And she has kids that did both, but we borrowed the money to do both because the federal government did make it accessible. I think a lot of people have, you know, heard a lot about the student loan crisis and different things. And they will let you borrow as much money as you want to go to school in this day and age, pretty much. But it may be at the rate of costly private loans, and often paying those back is difficult. Again, my sister, she borrowed $150,000 to go to a relatively elite law school, didn't particularly like the area of law she was working in, and she really was struggling to pay her $3,000 a month student loan payments when she really chose to follow a different passion and go back and become a nurse. So there's just a lot to consider with financial decisions that we all face every day. I'm not saying, again, these people in healthcare are in a relatively good market as far as job security goes, but the burnout rates are extremely high, and the financial investment to get where you're going is often quite high as well. So all those things really do need to be considered. So again, in developing AHV&M, I felt I took all the things that I thought were good from practices I've been part of, that I've helped build, large corporate systems that I thought there were good things about, and then things that I thought we could make better or change. And when we really developed our practice, we tried to do it in the sense of what could we do different? We started with a training week. That was an interesting thought. You know, I thought the people that we're going to hire, we are going to spend the very first week of the practice doing training sessions, really explaining our vision, our mission, what are we trying to accomplish. Now, several people had been part of developing the practice, but we had several people that were new. I wanted them to understand where we were going, what principles we would be founded on, what their role would be, and to really give them the education and knowledge. Now, again, could I do all of that in a week? No, but we could accomplish a lot. A shout out to Karen too, that's my mom again. I do have to say, Karen took a break from corporate America that week, and this is before she worked with us. She came out and answered the phone for a week. Okay, so we were transitioning from a very busy hospital-based practice to our own independent practice, and there was just some chaos in the middle of that. So Karen was the phone answer for patients that were not getting their refills, were unsure of where we had relocated to. And she also had not spent a lot of time in the Southwest, or evidently, she spent most of her time in the Midwest and New York.
But we did get one urgent message that Jose, H-O-S-E, needed his medications called. So we were like, Karen, Jose is actually J-O-S-E out here. So yeah, we came a long way in our pronunciation and spelling of all the different names and cultures that we have in our region. No, Karen was like, wow. She's like, I went from how hard could it be to answer the phone to please get me back to my other job because this place is insane. So with Karen answering the phone, we went through, again, our core values: integrity, compassion, safety, innovation, and transparency. I'm going to focus a little bit on transparency. I do think it's something missing in healthcare. And as part of this podcast, you're going to see a recurrent theme for My Homegrown Heart, which is going to include transparency. I am very open, I'm very honest, and I feel like integrity is really what we have in healthcare. As your provider, you need to trust what I say. And that doesn't mean you can't question it. I think in the past, sometimes physicians and providers might even have what we would consider, quote unquote, a God complex, or thinking they were all-knowing, omnipotent. And that's not how I feel. I feel like you and I partner in your healthcare so that we can try to come up with the best plan we can. I use my knowledge that I have and the training that I have to help give you the best advice that I could come up with. But I also utilize outside resources and other connected physicians to my network that I've built whenever I think that you have an issue that's larger, deeper, or more complex than what I can handle. On that note, I just got a message this morning from a Dr. Lauren Barron, and I just want to shout out to Lauren. She's at Baylor Scott & White in Houston, St. Luke's, and she is a cardiothoracic vascular surgeon that specializes in fixing aortic roots of patients that have connective tissue disease. Now, wow. A, how specialized is that? And B, how relevant do you think it is to the practice in rural Eddy County, New Mexico? And it turns out it's very relevant because we have a family here. We actually have several families here that have connective tissue genetic problems that make them prone to having what's called an aortic dissection. An aortic dissection classically is when you're, again, the root of your aorta, which carries all blood vessels in your body, splits and diverts blood into a secondary pouch so it doesn't go to your vital organs. This is often fatal. And Dr. Barron has been able to save the lives emergently of several of our patients. And one of these such families actually works with me. She's an important member of my team. And she has also been affected. We first figured it out from problems with her mother and her grandmother, got extensive genetic testing, and it actually turns out their entire family is affected. Again, at 27 years old, she's already had open heart surgery and 2 major procedures. So Dr. Barron was helping another family from here, another patient, and she was sending me, wow. One thing she really said is people that have connective tissue disease, again, this is Marfan's. We have a family, again, that has something called Loeys-Dietz. These are fascinating diseases, but it's almost like I kind of tell people, it's sort of like being double jointed, but it's of your vessels. So your aorta is so stretchy that sometimes it will just tear for no good reason. And it tears and causes potentially fatal outcomes in people at a much different rate than the average person that might get that same problem. An average person that does not have a connective tissue disease that ends up with an aortic dissection, it could be traumatic from a car accident or getting hit in the chest. It also could be from years of poorly controlled blood pressure will finally cause your aorta to get stretchy, and that will happen. But that's a lot different, as is the tissue from these patients. So anyway, Dr. Barron was messaging me this morning about the surgery went very well. She wanted to discuss with me the medication follow-up after. And I just can't say enough that part of the way we're able to have a successful cardiovascular practice out here is by using these connections so that we can have Dallas, Lubbock, Houston, El Paso, Albuquerque, Denver, Salt Lake City. We really have physician networks in all of those so that we can help our patients as appropriate. So that kind of goes into compassion, and we talked about integrity, but again, transparency. We're transparent at our practice. We're transparent about how much things cost, how long things take. Now that sometimes you might wait 2 hours at our practice. I think you've heard that last week too, and that could be the truth. So we do try to be very transparent though, and I think healthcare transparency about cost is a big issue. There are many patients, many employers have opted for what's called high deductible plans. That means you may have $10,000 to $15,000 out of pocket before your health insurance ever kicks in to help you with something. And I'll be honest, I'm guilty of being like, really, what do I pay this health insurance for? Because you pay for your health insurance, and then, which again is a struggle for small business. The lower number of people you have, the more difficult it really is to cover, the higher the premiums are. And then you need the health insurance, and all of a sudden you're like, oh no, you have a copay. Oh, that's part of your deductible. Oh, you haven't reached your out-of-patient maximum. You know, that same employee who's 27 years old that needed open heart surgery last year, and thank God did get some much needed support from both the community and our practice, but she had to come up with $10,000 out of pocket that day or not get her procedure. And that's pretty much the way it was. You know, they said, which credit card will you be putting the $97.50 on? And everyone does not have a credit card to put $97.50 on. And again, that's $9,750, not $97.50. And in a country that has so much money and so many resources, it is frustrating to me that the cost of healthcare often prohibits people from getting the procedures that they need. I'm on call at one of our local hospitals, and I just got called yesterday about a patient. They had been short of breath for several months with leg swelling, and they were in their middle age, and they had not sought treatment because they did not have health insurance. When I looked at the ultrasound that was done to their heart's actually quite weak, have some problems with their valves, and have really a very serious underlying heart condition. And it really upset me to think that this patient has suffered for months not wanting to seek care because they don't have any money to seek care. And that's really not acceptable in a country that has the kind of resources that we do in the United States. So I do think that part of our goal is to offer quality services that are at a reasonable price. And that's exactly what we're trying to do. And we were happy to share with anybody anytime what those costs are. And it's also, again, part of the reason I mentioned our foundation last week, that's Partners in Heart Health, has two major objectives: partnering with the community to really help our underserved, underinsured, uninsured population, as well as helping staff get the kind of education that they need so that they continue to bring those quality cardiovascular services to our region for the foreseeable future. So, to be successful in our mission, we're committed to several things. We strive to improve the quality of care and services that we deliver. We provide highly trained and responsive staff members. We ensure a safe and comfortable environment for our patients and our employees. We expand services and innovative technologies in response to the needs of our community. And we are appropriately transparent with patients regarding the cost, cases, and communication. And again, this is directly from our training week. This is what we taught our staff, who we are and what we'll be. Where and how did these ideas develop? It's always been my plan to re-enter independent practice. Many physicians choose large corporate healthcare structures and employment options, and I certainly understand the benefits and negatives of each. I've been involved in both sides of the system, and I've had several hybrid models of employment. CMS, which is Medicare, the federal government, actually approved putting stents in the heart in an outpatient surgical center setting. That was a big impetus to really, You know, sometimes you're at a crossroads. I've been a leader in corporate America. I've been chief of staff. I've been chief medical officer. I've often taken leadership roles at all the hospital systems that I've been part of over the years. I've served on committee. So CMS actually approved stenting the heart in a surgical center outpatient. And not to exactly age myself, but that's crazy for me in my career, because when I started in interventional cardiology, you were not allowed to put stents in someone's heart without an open heart surgeon available on backup, just in case somebody had a bad outcome. Now our outcomes have gotten better and better, to the point where elective, now these are not emergency cases, but that elective cases of a stable patient, maybe you had a stress test that showed you might have a blockage, or you came to me with chest pain that I thought was concerning. We can actually do your angiogram, which is a heart catheterization, as well as potentially put a stent in now in an outpatient setting. So that was part of the motivation, again, for really developing this outpatient practice here and Advanced Ambulatory Surgery Center of Carlsbad, New Mexico. There were longtime Carlsbad residents who were also philanthropists who sought an alternative local healthcare option, who wanted to be involved and help back low-interest loans and get this project going. We started having meetings. We did a feasibility study. We did pro formas. We did expense estimates. We did an overall project cost analysis. And now keep in mind, a lot of this was during COVID too. COVID didn't really slow us down, but it slowed down the world for many reasons. We remained committed to doing our project, but getting goods, getting meetings, all of these things were definitely slowed down pretty dramatically during that time. And eventually we decided to partner with Philips, who's a large player in the medical equipment world, for our cath lab equipment. And then we had a lot of different consultants who were really ambulatory surgery center and cardiovascular experts, as well as the engineering experts that we had involved, which that was more my partner's input than mine, because I do not know a lot about geoengineering and all kinds of different stuff that went into the build. And that'll be that's at least 2 sessions on the build of this place. We also had to evaluate the needs of rural Eddy County. And I said some of this last week, and I cannot overstate. You really have to see what is the overall physical, social, and mental health state and status of where you're trying to build a practice. You have to understand what exactly is going on. We have a relationship with the National Rural Health Division as well, which is really a large organization that's specifically designed to help meet the needs of rural America. And they're very good on trying to identify that one size fits all does not really work. Again, I think I mentioned somewhere between 25 to 30% of America is considered rural, and the other 70 to 75% is considered urban or suburban. But that 25 to 30% that our Southeast New Mexico is part of certainly does not, the answers for how to improve our healthcare infrastructure are not necessarily the same as the next rural place, Southern Illinois, where I grew up. Again, I think I've mentioned that I was, an hour and a half outside of St. Louis, a few hours south of Chicago. My rural place in Florida was 45 minutes outside of Orlando. That's just a very different situation than what we have going on here. Look at the quality of life. What is, is this a retirement community? Is time lost from work important to people? Which obviously that is, but can we avoid preventable deaths? What is our life expectancy in our current area versus what is it in an urban area? Rural residents' needs, again, do they have the financial means to pay for their health insurance or the cost involved if they don't? Do they have the means to reach these services like transportation? Can they take time off work? Do they have a confidence in their ability to communicate with healthcare providers? Again, particularly if the patient is not fluent in English or has an overall poor health literacy. Do they have a trust that they can use the services without compromising privacy? Again, this will be a recurrent theme, but cyber stealing and revealing patient information, hacking into healthcare systems is a big issue right now. And do they believe that they'll obtain quality care? I think that's a big important factor in our rural Southeast New Mexico population. A lot of people do not believe that they can get quality, sustainable health care in our region. I do believe they can, but there's a lot of pieces we have to put together of that puzzle to really encourage people's confidence. Again, we had to assess what we had, what services we did have, and what services we need. I can tell you one thing we're definitely missing are more primary care providers. That includes family practice, internal medicine. Are we appropriately utilizing our mid-level practitioners? Nurse practitioners can practice fully independent in the state of New Mexico. There are pros and cons to that approach, and I work with some very quality nurse practitioners who have amazing training and are certainly capable. I prefer a situation, particularly in specialty medicine, where nurse practitioners and physician assistants work in conjunction with the physician, and that is the model that I try to develop. We don't have dermatology, rheumatology, GI specialist, so all of these things, a vascular surgeon, we have a vascular surgeon who does some work, but he's currently out. So there's room for a lot of things to improve in our region. Overall care is being transitioned towards outpatient facilities, including surgical centers. And as I really looked down the barrel of what does the next 5 years of healthcare look like? So if this is 2018, 2019, and I'm really looking ahead at where do I see myself? Where do I see this region? Where do I see healthcare in general? Where do I see rural health in America? Kind of looking at stuff, trying to figure out what is the best thing that I can do to make the biggest difference, to reach the most patients, and that is always the goal. What can we create to reach the most people, providing the most quality services? So that's kind of how this developed. It has to be driven by quality, cost, and safety, as well as overall patient comfort and the patient experience. There's a big thing in healthcare right now that's called value-based healthcare. Traditional healthcare in America is called fee-for-service. I do a procedure, you pay me X dollars. The government sets what that X dollars can be. However, there's a lot of, every different insurance plan will have a different contract with each different provider. And that amount of money will vary from every different provider, from every different facility, exactly what they pay for that service. And that's one thing about healthcare that I don't really like that aspect, and I'm not really sure why it's done like that. I prefer a situation where we decide what is fair for a procedure or a test to be performed, and that's the amount that you get paid for that procedure, and that's the end of the story. Now, there is going to be a lot of variance person to person, and you can't always know an exact dollar amount that is cost of care, but we should be able to get averages, and they should not be so variable. For example, they're doing an ultrasound on someone's leg at our practice. We do that procedure for $200. And there are some insurances contracting with some hospital systems where that same test might cost $12,000. And I'm not sure, but that doesn't make sense to me. I don't know why something costs $200 at one facility and $12,000 at the next facility. It's the same $80,000 ultrasound machine, and it's the same tech that's getting paid $100 an hour to do the study. So realistically, I don't know why it costs $12,000, and I don't support that it does. So I'm committed to trying to figure out how we can equal out some of these prices. That's one way. But again, this whole value-based healthcare, that's saying a little more, instead of getting paid for each thing that you do or each patient, that it's somewhat of a, if you have good outcomes for a certain, let's take all your patients that had a heart attack. Let's say in a year, you had 100 patients that had a heart attack. if you get X dollars based on what outcome you had for those patients to provide care to those patients, then that would be more of a value-based healthcare system. And I like it. I love it. I like the idea. A lot of us in healthcare do. The problem is we haven't really figured out how to shift really effectively from a fee-for-service system to more of a value-based, patient-centered system. So Advanced Heart and Vascular Center of New Mexico is definitely here to be part of creating value-based healthcare as we go forward in the next 3 to 10 years. We hope we're able to be part of that. Again, what we have built, this Regional Cardiovascular Center of Excellence, that was the goal. We've built a team of specialized staff from office, clinical to administrative, to cath lab development, to development of nurse directors and lead techs. We have a clinic that at the time saw over 5,000 patients a year, had a patient population of about 2,500. So with 1 interventional cardiologist and 2 cardiac nurse practitioners. We had a primary cath and stent program that was doing 1,000 cases a year. Program started in 2015. It was pretty much Carlsbad and Artesia patients. It started with 50 patients prior to my arrival and us developing the program in 2015 and then launching in 2016. Quickly built that program up, and COVID provided an opportunity. We provided care to people from Lovington, Roswell, Ruidoso, Brownfield, Gallup. I mean, we really took patients from all over. We did what we could to be part of the solution to which was really a lack of healthcare beds at the height of the crisis. You really have to have a service line approach. In its simplest explanation, it's really a reorientation of strategy, resource planning, and allocation of the horizontal continuum across provider entities. Versus a vertical oriented approach. So what it's saying is you can't silo healthcare. The cardiologist sends you to the neurologist, who sends you to the rheumatologist. They don't communicate with one another. Each person's ordering their own test. So you really have to develop a little more of a patient-centered approach to this delivery of healthcare. It needs to be organized in the way that a cardiovascular patient, for example, in our industry, experiences healthcare. Looking at what do we really need, again, remember this is April of 2022. This is the presentation we gave for our new staff. We needed additional cardiac catheterization lab because we'd had a growth of our cardiac cases and expansion into peripheral vascular cases, working on leg veins, leg arteries. So we had 1 cath lab accomplishing all of this, just not realistic to serve the entire region with 1 cath lab. There was an increase in blood clots that was noted both from COVID as well as from the vaccine, special procedures for catheter-directed blood clot drugs to be delivered to these blood clots that became a lot more prevalent during COVID. Difficulty staffing multiple rural communities with high-quality cardiovascular physicians, radiology techs, cardiovascular nurse specialists, respiratory therapists, medical assistants with specific cardiovascular training. So there's just a lot of advancements needed to happen. So Advanced Heart and Vascular Center of New Mexico, as well as Advanced Ambulatory Surgery Center of Carlsbad, New Mexico, were developed. 5,000 square foot, 10 patient exam room cardiovascular practice, separated by a state-required firewall, with an 8,500 square foot cardiac cath lab, operating room, minor procedure room, cardiac cath labs with stents primarily being put in through the wrist. We have the ability to go live with our procedures. Our cath labs were set up with an idea that patients and families can watch the procedures if they choose to. Again, transparency. It'll make you feel a little uncomfortable sometimes in healthcare, and that's not for everybody. Everybody doesn't want to watch their family member have a procedure, but we do want our families to be able to watch those procedures if they choose to, and to be able to ask we have a member of the staff sit with them so that they can ask questions and understand what's going on. We have the newest technology available. We do echocardiograms, stress tests, work on people's legs, arteries, and veins, laser treatments available, and catheter-directed treatment of patients' blood clots. The goal is to really create a model that has an interventional cardiologist with at least 4 mid-level nurse practitioners that have at least 6 months of advanced cardiovascular training. Offices in Carlsbad, Artesia, Roswell, and Hobbs. Recruitment of a second interventional cardiologist. 70% of our cases will be done at our outpatient surgical center. There'll be some people that are still too high risk or for different medical problems they have. We feel that they're more appropriately done in a hospital where we will continue to maintain our privileges and do some procedures, including emergencies. Strategic partnerships with regional hospitals and healthcare systems and physicians at tertiary referral centers. Again, we cannot build this program without partnerships. Constant patient data tracking, reporting, and surveying. A state-of-the-art technology that is upgraded frequently. This is a big issue in healthcare. It's very expensive. Our cath lab equipment costs over $2.5 million just to get it going. So you really have to, and the service contract alone is $18,000 a month to have a service contract for it. So if you just, the complexities of these equipment is just hard to even explain at this point. But if you want to be able to provide the latest care to patients, you have to upgrade your equipment. Appropriate use of IT, talked about that a little bit last week, but you cannot overemphasize IT development in healthcare. There are so many ways and options that we can grow, learn, and improve utilizing appropriate information technology and information systems, but it has to be done in a way that patients' data is protected to the nth degree. Continued involvement with community leaders. I do my very best. The busier I get, the harder it gets, but I have a whole team of people that participate, such as Ms. Tammy Wacker and Veronica Ramos, Summer Gonzalez. So those are some of my team members that you may know. They are out there in the communities getting to know everyone, participating in Rotary, in development leagues, in meetings with the mayor's office, in senior center involvement. You know, we really want to hear from the community what your needs are, what your feedback is. And by the way, we know our phones are crazy. That's feedback that and I've said, you know, I love a live person answering a phone. It has always been my goal, but my goodness, again, as we've gotten to 9,000 plus patients in a patient panel, it's gotten more and more difficult to make that happen. So we want to encourage the use of our patient portal. We answer portal messages. We have remote trained workers. Some people I worked with in Florida years ago who work remotely now, understand our practice, participate in our weekly meetings, are in contact with me 5 times a day. And so utilize that portal to send your patient messages when you can, and you will get a prompt response. And then we need physician and clinician-led management and initiatives. In part of the frustration that corporate America had with my decision to really build something that was a little different and go away from the traditional model, someone said to me, "You think you can do it better than we can." And it maybe wasn't said that nice, but I smiled and said, "Yes, actually, I do. I do think I can do it better." It's just about being different. I do believe in physician and provider staff-led initiatives. There is a different way that healthcare administrative people are trained. And again, I have a healthcare executive MBA. I went to school with many other physicians getting that degree, as well as executives that were at directors level and all kinds of different backgrounds, some that were straight through college, some that had worked in the healthcare sector for a long time. And there is a definite difference between the way even physician executives in healthcare are trained and executives that are not clinical are trained in a very different manner. I've sat in a lot of meetings. I was reliving a CFO conversation that I had with somebody a couple weeks ago. And this was at the height of my decision to leave corporate America. And they said, I wanted 2 different stent lines available for what's put in your heart. Of course, they have a corporate contract that if they use at least 90% of one stent brand, that they're getting a less price. And I support those initiatives. Cost matters. I mean, yes, your health matters, but we do have to keep the doors open. And I do support cost initiatives. But I also think there are times when you need a second option. Sometimes one stent just is a little more flexible. It's made in a little different length and a little different width, you know, different stuff like that. So we were at 97% compliant with the one company, but the CFO wanted us to be 100% compliant, of course, because that would be great at the corporate meetings if we could be 100% compliant. I was like, well, we're meeting the 90%, and there are times I need a second size, you know, a different one stent will traverse the artery better than the other. You know, it's just trying to explain this to a financial person. I was like, can't you just put more, you know, a longer stent or a shorter one in? Do you have to put the quote unquote right size? I kind of took a step back and I was like, you know, the size of stent and the length and the width that needs to be put in a patient is 100% a physician decision. This is not, I spent 15 years and borrowed $600,000 to go to school and walked out the door at 35 ready to start my career. And all of that made sure that I knew what size stent you needed in your heart. So we're gonna go with what size stent I think we need. And yeah, no, this is not a let's get close and you know, that'll be good enough. So no, we actually did, we kept the two brands for then, but I had to continue to advocate for it. So here we are. Again, I talked a little bit about me last week too. This is not all about me. This is about the practice. This is about developing and changing rural healthcare. This is about the loyal group of bright, qualified staff that I have around me and getting them to really, my goal is to really build this up and get it where it needs to be and be able to expand our service lines to other regions as well. In doing that, it cannot be Dr. Amanda Ryan's focused and centered. It has got to be on a team approach. That team includes the entire community. It includes the patients. It includes the staff. It includes potential staff that have an interest in joining us and being developed. Working with our local community college to make sure that we're getting those programs up to speed. We've developed our own cardiovascular program for training techs, which I'm going to share a little bit of that with you as well. The three most important aspects to building trust are transparency, transparency, and transparency. Transparency in data, in objectives, and in everything required to build credibility and trust. The ability to watch and stream cases, a price list with open discussion, surveys that are both where they are anonymous and name given. You've got to do that 360, whether it be with your staff, with your patients. You've got to go back and see, how was your experience? Where could we have done better? And we're doing those. And it's great when Tammy says, oh, I talked to all the patients and everything was wonderful. And that, you know, she gives us all the answers. But you know, the ones that probably mean a little more to me are when I hear things were good, they had an overall good experience, but here are a couple ideas for things that could have been done better. They couldn't reach somebody the day of procedure and led us to decide that we probably need a phone that is just designed for who's ever in charge of the surgical center on that day to have that phone, and we will give the number directly to the patients getting procedures that week, and they can call that phone specifically. So from negative feedback comes ideas for how to get better too. That's important. I was raised with a lot of constructive criticism. Nobody just told me, first of all, my friends were never at fault for the things that happened. In my parents' view, I was typically, and that's probably appropriate because I was probably the ringleader of any small mischievous things that we might have been doing as children or teenagers. But constructive criticism can be hard to take, particularly when we're working so hard. I think I calculated the other day, Karen and I for sure, and many members of our team are somewhere, I'm working about 100+ hours a week right now. And that's a lot. And I realize it's not completely healthy nor totally sustainable. but it's a startup, and it has a big startup without startup volume, by the way, because the volume is not startup volume. But you've got to be able to manage that. We've spent years building this infrastructure, but it's exploding so fast, and I have so many different areas that I really want to develop that this is just what's required right now. So we'll get there, and we'll have, shout out to my husband and my lovely little girls who are in Florida living their lives, and take from their bonus mom whatever time we can. We make sure we have a great time, quality conversations on the phone, FaceTime, and my husband is very focused on making sure that they have all the experiences that they deserve at their age as well. So it's not traditional, but it works for us. All right, so developing a little bit of ambulatory surgery center meant creating a cath lab academy. Stacy Slaughter is the director of our cardiovascular cath lab. He is an amazing, well-trained RCIS, which is a registered invasive cardiovascular specialist. He's also a trained echosonographer. He trained in the military. He can do echocardiograms. He can do cath labs. He's about to finish his PhD. He has several master's degrees in the education and cardiovascular realm. So he chose to come and help get our program to the next level. Many people participated in getting it to where it was, and then Stacy kind of came in and is helping us really build the ground floor of several cardiovascular professionals becoming specific cath lab professionals. So that's something that we're really working on developing. Advanced cardiovascular technology. The program is really it's occurred over the past year. We're basically training technologists to operate sophisticated equipment and assist the physician in diagnosing and treating patients with cardiovascular disease. The real focus is on these invasive cardiovascular procedures. And so we have a well-developed curriculum. We have a lot of on-the-job as well as educational sessions that have set up. And again, we've already been doing this for about a year. And our first group is about 6 months into their formal education. And we're looking at forming some partnerships with colleges so that we can get them the appropriate healthcare certifications and degrees. They will be available to sit for the registered cardiovascular invasive specialist examination at the culmination of the plan, as well as once they've participated in about 600 cases, which is a very large requirement. But there's such variability in the procedures you do in the cath lab, and even each patient is different. So before you become an expert, you really do have to be exposed to a lot of different cases. So actually, back in my training days, you had to do 1,000 cases before you were able to be ready to be on your own. And so here I am, probably about 15,000, 20,000 cases in at this point. But it's fun to go back and train people that are learning, that have a desire to really help their community. So I think that's going to wrap it up for this week and what we're really trying to accomplish. Again, we're going to talk about some real details of different interventional cardiology procedures. We're going to talk about the realities of being a woman in a highly male-dominated cardiovascular world of healthcare. We're going to talk about the business, financial aspects of healthcare as they pertain specifically to our cardiovascular programs. We'll talk about patient needs and different options that we have to help those patients. So this is going to get more and more in detail. And if you have things you'd like to hear about, talk about, we'll be taking suggestions. And we'll see you next week.